Our first speaker is Dr. DEBASIS CHAKRABARTI. He will be speaking on evaluation and mimickers of primary congenital glaucoma. Dr. DEBASIS did long-term fellowship with us at L.V. Prasad Eye Institute in the year 2006-2007. Now he is consultant at Center for Sight, Kolkata. DEBASIS, please.
Thank you, sir. Good evening, everybody. At the outset, I would like to thank Dr. Mandal for giving me this opportunity, and it's an excellent opportunity to share the stage both with Dr. Sirisha and Dr. Mandal, who are my teachers. So before management, we always start with the evaluation and mimickers. So the proper evaluation is, of course, important, and we must understand that the prompt diagnosis of childhood glaucoma and appropriate treatment can minimize the degree of visual impairment, and there are certain mimickers which we must be aware of. So although primary congenital glaucoma is basically IOP-related damage to the eye, but measuring the IOP itself can be tricky at times, and some of the other signs of glaucoma in this age group, such as the ocular enlargement, HAZE, STRIAE, they become important. So according to the CGRN classification, the primary childhood glaucoma consists of the primary congenital glaucoma, the juvenile open-angle glaucoma, and then we have a host of secondary childhood glaucomas. Now, primary congenital glaucoma, as we all know, is the most common form of developmental glaucoma, and the isolated maldevelopment of the trabecular meshwork, that's isolated trabeculodysgenesis, is the main pathology. So before the examination, we always start with a history, and we start with the age of onset of symptoms or signs. The classical features are epiphora, blepharospasm, corneal haze, and opacification. We must also inquire about rubella, maternal rubella, delivery history like the use of forceps, and very importantly, the history of consanguinity and the glaucoma in siblings. Now, although most Western textbooks describe a classical triad of epiphora, photophobia, and blepharospasm, probably in the Indian subcontinent, the more common clinical features are large eyeball size and hazy corneas. There are certain other presenting features, like Dr. Mandal et al. Published a report of 31 cases over 23 years who presented with acute eye drops. The vision has to be assessed by the age-related, age-appropriate methods. And the most important examination part is the examination of the anesthesia, and what we look for are the refraction, the corneal findings, the intraocular pressure, gonioscopy, ophthalmoscopy, and then and there on the table we take a decision for surgery. Now these are the requisites for examination under anesthesia, and a few points about the choice of the anesthetic agent. All anesthetics and sedative agents lower IOP with a few exceptions like ketamine, chloral hydrate, and benzodiazepines. And it's very important that the IOP should be recorded the moment the child stops moving after inhaled anesthesia and prior to intubation, or else we'll get an erroneous measurement of the intraocular pressure. Now the IOP, classically, it has to be measured by the Goldman applanation tonometry or the Perkins, but the tonopen and the eye care have also their advantages. Now, once we start evaluating, we start with the cornea, and the extent of the corneal haze gives some idea about the severity of the glaucoma, like whether we can see up to the pupillary margin or the iris details or the fundus details. Now, the corneal diameter has to be measured in each and every case with the calipers, and we measure the horizontal visible corneal diameter. It's a white-to-white diameter. The normal measurements are, it's about 10 millimeter at birth. Any measurement greater than 11 millimeter in the newborn, or 12 millimeter in a child less than 1 year of age, or 13 millimeter at any age will be considered as abnormal. The corneal striae are important. The HAZE striae, characteristically, when they're seen in the periphery, they're concentric to the limbus. When they're seen in the center, they are horizontal and located near the visual axis. They must be differentiated from the forceps injuries, which are vertical, unilateral, and central, often associated with periocular bruising. Now, gonioscopy, in the normal newborn eye, the iris has recessed beyond the scleral spur, so the scleral spur is visible as a whitish band. In contrast, in primary congenital glaucoma, the characteristic finding will be that the peripheral iris inserts to the trabecular meshwork and the scleral spur is not visualized. Then we come to the fundus. So we look at the fundus, not only on the optic disc, but the peripheral retina also for some of the other differential diagnosis. And a cup disc ratio of more than 0.3 in an infant or about 0.5 in an older children is will be considered as suspicious. And we know that striking reversal of cupping can result with IOP reduction after successful glaucoma surgery. Regarding the pachymetry, it is probably not as important as in adult glaucoma. However, it can influence the accuracy of the Goldman applanation tonometry, and what the CGRN recommends is that the CCT should not be used to adjust an IOP measurement, but rather taken into consideration in the overall context. Now, coming to the axial length, the absolute value may not be important, but even after we have operated a patient for pediatric glaucoma, sometimes it's important to evaluate the axial length, because an increase in axial length on subsequent examination is a sensitive indicator of progression of glaucoma. The cupping may not be may be very difficult to detect at times. Now, B-scan is to be advised in absence of a good view, and very importantly, it can provide critical information about SOLs, and there have been misdiagnoses where retinoblastomas have been misdiagnosed as primary congenital glaucomas. So whenever there's a hazy cornea, we should always go for B-scan. Now, coming to the second part, what are the mimickers of primary congenital glaucoma? By and large, we can clinically easily diagnose that this is a child with primary congenital glaucoma, but there are important mimickers. So these mimickers can be because of epiphora, because of the other differential diagnosis of congenital corneal clouding, enlarged cornea, or congenital disc anomaly. So if we see what are the causes, other causes that can cause epiphora in a child, this can be nasolacrimal duct obstruction, conjunctivitis, corneal abrasion, keratitis, uveitis, and so on. The differential diagnosis is clinically not very difficult to differentiate. Now, this may be important, the differential diagnosis of congenital corneal clouding. What are the other common causes that can cause corneal clouding and can mimic congenital glaucoma? So, Peters anomaly will be a very common differential diagnosis. According to this study, these were the various causes according to the percentage. So, these are Peters anomaly, sclerocornea, dermoid, birth trauma, and metabolic disease apart from the congenital glaucoma. So there's a mnemonic called STUMPed, where we can remember what are the common causes that can cause congenital corneal clouding. And then coming to the differential diagnosis of the enlarged cornea. So the enlarged cornea can be, apart from the primary congenital glaucoma, it can be because of high axial myopia or because of megalocornea. So megalocornea is a rare developmental defect which is characterized by non-progressive, usually symmetric bilateral enlargement of the corneal diameter greater than about 13 millimeter. And the steeper cornea usually results in with-the-rule astigmatism and myopia. But here the cornea is clear and of normal or slightly below normal thickness. These children have very deep anterior chamber, and this is associated with phacodonesis, iridodonesis, and ectopia lentis. Megalocornea often occurs as an isolated condition or can present with multiple ocular or systemic associations, example Marfan's. So megalocornea is also an important differential diagnosis. And lastly, we can have the differential diagnosis of optic nerve cupping. So again, all these conditions, they are rare, but sometimes they might confuse you, like optic nerve hypoplasia, superior segmental optic nerve hypoplasia, tilted disc syndrome, optic pit, optic nerve coloboma, morning glory disc anomaly, and so on. So my take-home message would be, we should always have a low threshold for suspecting congenital glaucoma. For obvious implications, we have to diagnose these patients early, because the only treatment available for these children is surgery, and the earlier we do the surgery, the better, because apart from the IOP-related damage, persistent corneal edema can cause corneal scarring and will have a long-term outcome. Now, the increased corneal diameter for age should heighten suspicion. Sometimes parents think that the large size of the eyes may be a sign of beauty, but we should be skeptical, and there should be a high index of suspicion whenever we find a child with enlarged corneal diameter, and if necessary, we should do UA for these children. So UA is essential in most cases to know the exact etiology, and we have seen that the IOP should be measured as soon as we do the UA, and the corneal diameter should be measured, and the fundus should be evaluated, and all the mimickers we should keep in mind before we can diagnose it as a case of primary congenital glaucoma. And we should also remember that there may be multiple etiologies in the same child. So there can be multiple etiologies, and those have to be identified before we take the child for surgery. Thank you. I think I finished a few minutes ahead of time.
Thank you,
Any comments by Dr.
for comprehensively covering the whole topic.